dermatology, both medical and cosmetic dermatology, and I'm here to speak to you about male and female pattern hair loss, a subject that's very dear to me because I started in this area when I was starting losing my own hair at the age of 19, and it became a very big interest to me because you always try to solve your own problems more and you come up with the best solutions. So what we're going to talk about is both male and female pattern hair loss, common pathophysiology of the diseases, and the newest treatments. Just a little bit about my background. Very quickly review the hair cycle because it's very important in the fact that we go through 3 different stages among hair growth. This is the hair growth that happens throughout the body. We have the anagen phase, the catagen phase, transition phase, and the telogen phase. And as you all know, during the anagen phase, the hair grows longer and thicker. It may be 3 to 6 years occurring on top of your scalp, or it could be as little as 1 or 2 months in your hairs that happen on your eyebrows or your eyelashes. Now we have the transition phase, which is the catagen phase. The hair stops growing and begins to get detached from the hair follicle. This only occurs for 2 to 3 weeks. It's only occurring in 1% of the hairs. And which represents the last stage is the telogen phase, resting phase. The hair follicle becomes inactive, and only 10% of the hairs are in this phase. Now what happens in androgenetic alopecia is that for both, also referred to as male and female pattern hair loss, it represents 95% of all hair loss. So 95% of individuals that come into your office have male or female pattern hair loss. And if they also come in for telogen effluvium or even for alopecia areata, androgenic alopecia should always be looked for and always be treated because it's a concomitant disease and it occurs in 19 and 20 persons with form of hair loss. It's non-Mendelian, polygenetic. It can come from both your mother or the father's side. And it can start anytime after puberty. The reason that's very important is after puberty, the hormones are changing within the body, and not only acne could occur on the face or in the body, but the androgenic alopecia is the earliest stages that are to occur. Now, androgenic alopecia is a very common disease. 300 million people in the United States, 50 million men and 30 million women are affected by this. I would say that this is underestimated by the American Academy of Dermatology. In fact, if you notice, majority of women coming into your office, they say that their hair starts to thin after the age of 30. And that's because the hormones start changing around within the body. After 25 or 30, or 5 years after that, both the males and females have dramatic changes within their hormones. And for females in particular, their hormone cycle, they started noticing that their hair is thin. They don't really attribute it to a disease, they attribute it just through a natural process, but that is still considered female pattern hair loss. And as we all know, it's very easy to diagnose a male pattern hair loss. You could have thinning in the front of the scalp, you could have thinning in the back of the scalp, or it can involve all throughout the top of the head. For the males, in the Norwood scale, you guys have all seen this. For the female, again, it's a little more ambiguous. Most of the women that come into my office, they say, well, my hair is thinning, but my mother has thinning hair, my sister, my aunt have thinning hair. Well, it's not just a genetic condition where you have thinning hair, it's actually a disease, and it's the female pattern hair loss. If they start noticing that they're grabbing their ponytail or grabbing their hair, they notice less hair, there's less density, they are suffering from female pattern hair loss. And the earlier it is diagnosed, the better the outcome is going to be. You could have very early stages where, again, the part is beginning to be shown, retention in the frontal hairline, or the entire top of the scalp being involved. Again, finding it the earliest stages is most important and can be much more effective for that. So what is androgenic alopecia and how is it formed? Well, we say androgenic because it's hormone related, and it's due to the negative effects of DHT or dihydrotestosterone to the hair follicle. And DHT is a more potent form of testosterone, and is produced not just by males but also by females, and it is formed through the enzymatic conversion of testosterone into DHT by 5-alpha reductase. Now this is very, very important research, and this is around the time when I started to lose my hair. We began to understand what was the real cause, what was the initial process over here. And one of the great journal articles is Journal Investigation on Dermatology that found that increased androgens within the sebaceous gland, and the conversion led into androgenic alopecia. So what does the DHT do? Well, we saw earlier that we have the anagen, catagen, and telogen phase. DHT shortens the anagen phase, where you have normally 90% of your hairs in the anagen phase, and it increases the amount of time into the resting phase, which would be the telogen phase. Not that you necessarily have more telogen hairs, it's that more of the proportion of the hairs become more into the resting phase. And the DHT, with it's causing the hairs to grow for a shorter amount of time in the anagen phase, become shorter, finer, and thinner. Imagine if you have a tree or a density within a forest. If you're not allowing those trees to grow for a long period of time, your forest is not going to be very dense. You're going to have a very thin, sparse forest. But if you allow it to grow for a longer period of time, you can have long, thicker, bigger trees. It's going to increase your density. Again, same thing happens with male and female pattern hair loss. The DHT shortens the growth phase, resulting in stunted hairs, just like you would have stunted trees. And very importantly, understanding where the hair follicles are affected by DHT, we could see that the vertex, mid-scalp, and the front of the scalp are the areas that are sensitive to DHT, as compared to the peripheral hairs, the occipital scalp or lateral parietal scalp. And this was demonstrated in a British Journal of Dermatology study in 2006, when it was these patients, these males, were given finasteride orally, and they saw that the ratio of the DHT to testosterone was actually decreased when the finasteride was given, as compared to the periphery of the scalp, meaning that these hair follicles were sensitive to the inhibition of the DHT because they are affected with hair loss. Again, what happens with DHT? You're decreasing the growth phase, increasing the amount of thin proportion that they're in the rest phase, resulting in finer, thinner, colorless, or miniaturized hairs. And this could be demonstrated here. Normally we have nice, thick terminal hairs growing onto the scalp. The hairs extend all the way down into the reticular dermis. So they extend all the way down into the I apologize. So the hairs extend all the way down from the reticular dermis all the way up, nice thick density of the hairs. But when you have testosterone through 5-alpha reductase, and this is the majority through 5-alpha reductase type 2, gets converted into DHT, and this is a process that happens over years. When the hairs get shed into the process, the anagen, catagen, telogen phase, you get finer, thinner hair. That's the miniaturization process that happens within the scalp. Over time, your hair becomes stunted, becomes shorter, they become the miniaturized hairs. We'll show that one more time. Again, through testosterone, through 5-alpha reductase, and this is again for both males and females, testosterone attaching to, dihydrotestosterone attaching to the androgen receptors, and over time, reducing the time that the hair is able to spend within the anagen phase, where it's going to be growing finer and thinner. That is a miniaturization process. That's where your hairs go from a nice thick to the very finer hairs that you could have on your body. So what got me interested in this again was that I was 19 years old. I was about to go to medical school, and I was starting to lose my hair. It became a very panic mode for me. I quickly diverted my research from transplantational rejection and rejection of small bowel and pancreas into really finding out what was going on. And again, luckily during that time, we began to understand that DHT was the cause of hair loss. And that's where I came and formulated my own product, and the product would be a topical formula called Revivagen, and it reduces the effect of DHT onto the scalp by inhibiting the 5-alpha reductase and inhibiting DHT from attaching to the hair follicle. It's a topical formula placed on the scalp at night for both males and females, and over time it reverses the hair loss process. And there's also a shampoo. The shampoo does not work to reduce DHT. It cleans the scalp from DHT, but as you well know, the majority of your patients that come into the office have a lot of shedding that happens within their scalp. They also have seborrheic dermatitis, or inflammation within the scalp. And when seborrheic dermatitis or inflammation occurs into the scalp, it's not the best environment for hair growth. And in fact, the majority of these patients are suffering not just from the male or female pattern hair loss. They come into the office because acutely they have the inflammation within their scalp. They're shedding a lot of hair, and it brings their attention into their finer hair. So the shampoo part of it helps for the seborrheic dermatitis. And it also comes with a conditioner, again, reducing the inflammation within the scalp, providing a nice environment for the hair to grow. So how Revivagen works is that it blocks the androgen receptors within the hair follicle, plus inhibits the 5-alpha reductase. Now it does it by inhibiting both 5-alpha reductase type 2 and type 1 with natural ingredients. To show that again. Again, the Revivagen blocks the androgen receptors and also blocking the 5-alpha reductase, maximally inhibiting the effect of DHT, which is the first phase of hair loss. And this has been well documented in that patients who have a genetic deficiency of 5-alpha reductase never have hair loss, never have acne, and they never have any enlargement of prostate or prostate cancer. So when Revivagen is used, the finer, thinner hairs, the miniaturized hairs, over time get replaced by nicer, thicker hairs. So you're not regrowing hair. What you're actually doing is you're taking hairs that are finer and thinner, and you're making them longer and thicker. And this is very important to understand because no product, whether it's minoxidil, Rogaine, Propecia, none of these products actually regrow your hair. They take the miniaturized hairs or the baby hairs and over time convert it and make them longer and thicker. And that's, again, very important that if a patient comes to you and they're Norwood scale 7, you see that their scalp is completely bald, they have no visible hair follicles over there, you're not going to be able to regrow their hair. And if you have done biopsies on scalp on patients who have Norwood 7, if you look through the scalp, you look at both vertical and horizontal sections, the hair tract is gone. There may be the erectopilus muscle, but there's the track of the hair follicle is gone. Although we don't call male or female pattern hair loss scarring alopecia or cicatricial alopecia, there is definitely scar within the hair follicle, and you cannot regrow that hair unless you incorporate other therapies, including transplantation, follicular neogenesis, or gene therapy. Now, the ingredients within Revivagen are unique in that they work like finasteride in reducing the DHT. And the two main ingredients are gamma linolenic acid and alpha linolenic acid. And these free fatty acids, again, they're in the free fatty acid form, they're not attached to the triglyceride, are able to inhibit DHT production through inhibition of type 1 and type 2 5-alpha reductase by 98% and 90%